Good afternoon, everyone. I'm Corby Kummer, Executive Director of Food and Society at the Aspen Institute. Welcome, everyone, to everything you need to know about the past, present, and future of food as medicine, or a healthy and healthful portion of it. We're lucky to have three of its main architects, people who do more than they talk, though they speak beautifully. I'd hope they'd say yes, because with vision and purpose and diplomacy and persistence, they get things done. Each panelist will talk for a few minutes about how they came to be involved with food as medicine, and I'll give a micro summary of how I did, since so many people I deeply admire are right here with us. And the people I talked to and wrote about in my decades as an editor and writer and food critic. That allowed me to see the food industry from many angles, including as a consumer and even a cook. But the one that interested me most was where industry could improve products toward better health. Two major influences changed my own direction to food as medicine. Long-standing involvement with the Boston community servings, which began delivering from scratch meals to people with HIV, but became a pioneer in what became known as food as medicine. And its enterprising founder, David Waters, is right here with us this afternoon. And he's been speaking at the Health Festival. He's broadened the field and its impact and ways to reach people and lives whose health will be improved by more healthful diets. And I had the infinite good fortune to marry a public health official whose everyday life for decades has been making the healthier choice the easier choice. John Auerbach, raise your hand. And it was our work with community servings that brought us together. The third major influence was understanding how much change could be made by bringing people together to share views, particularly strongly contrasting views, and constructively engage with each other to change the food system towards sustainability, equity, and better health. Our first major project at Food and Society was the Food as Medicine Research Action Plan. Hilary Seligman was our guiding force, and someone I got to meet thanks to Ruth Katz's Health Medicine and Society program of this very festival. She's still the central guide. Our guide is still the central one to peer-reviewed research on nutrition interventions in health, much of which Hilary led along with Seth Berkowitz from John Lumpkin's State of North Carolina, although he was originally in Cambridge, who began working with community servings on the same questions. And now we have the Food Leaders Fellowship, which every year brings together 18 emerging and mid-career leaders in food. I draw constant inspiration from them. I can't wait to meet our fourth cohort right here in Aspen in August, and we have the luck to draw from 461 applicants for 18 spots. We'll be hearing from about the impact food has from a panel of three personal heroes. Hilary, John Lumpkin, the most effective implementer of statewide food as medicine efforts, thanks to his winning belief from Blue Cross Blue Shield of North Carolina, and knowing that the key to acceptance and success is engaging with dozens of community-based organizations. And Wendy Slusser, who has implemented nutrition awareness and education across all of UCLA Medical School and the UC system, often in partnership with Hilary at UCSF, and whose own roots, as we'll hear, began with community work. Throughout our panel, and we've bitten off a lot, we'll be emphasizing the very imperfect term food is medicine and how it's used by healthcare systems and researchers, which is using free nutrition-based interventions such as medically tailored meals, medically tailored groceries, and produce prescriptions to prevent and treat chronic illness, chiefly diabetes, hypertension, and metabolic syndrome. Just 2 weeks ago, we met in Tucson, thanks to Ron Stout, who's also here of Ardmore Institute of Health, to talk about these definitions, but you'll be hearing a lot about them from Hilary, John, and Wendy. Hilary, could you tell us how you got into this in the first place and became a leading light?
Thank you, Corby. I am an internal medicine physician by training. I practiced for 15 years doing primary care medicine at the Safety Net Hospital in San Francisco. And many, if not most, of my patients had obesity, diabetes, diet-sensitive chronic diseases. And for all of them, I could write a prescription for metformin or now for Wegovy or for whatever medication I felt was indicated as a physician, and that prescription would get faxed or hand-delivered to a pharmacy in the back of the grocery store, and there was a system in place where somebody would package up that medication, the metformin or the Wegovy, and they would hand it to my patient, and in most cases, my patient would get that for free. But in most cases, or in many cases, what my patients really needed was access to healthy food. And the produce section was sitting not 50 feet from that pharmacy in the front of the grocery store, but there was no system in place to allow my patient to take a prescription to the front of the grocery store and fulfill something that arguably could be even more important for their health, at least in the context of prevention. And so that's really what brought me to this field. We know that 42% of Americans are obese. Almost half of heart disease deaths in the United States are due to heart disease. And we've done an exceptional job of allowing the health system to bring really phenomenal medical treatments. But fundamentally, healthy food and access to healthy food can be a really potent driver of improved health too. And so that's really what drove me to work on these issues.
But didn't you see that you needed research and data to back it up?
Yes, we need research and data to back it up. And so fast forward, I have spent many years now looking for the evidence that the healthcare system is a good place to be delivering nutrition services. Now, let me just back up and say fruits and vegetables are good for you. Healthy food is good for you. Hands down, we don't have to prove that. Your mother probably taught that to you when you were 4 years old. We are often asked to prove that healthy food is good for your health. We don't have to do that. But what we do need to show is that the healthcare system is a good place to deliver these services, that we can effectively reach people who need them, that we can provide them with the service that they want, like a medically tailored meal or medically tailored groceries or a produce prescription, that will change their behaviors so they improve their dietary intake, and that we can then support better food security, better health outcomes. It's been quite easy to show that these interventions improve food security and diet quality. When we give people fruits and vegetables, for example, and lower that financial barrier, improve access, people eat them. Not surprising, people in America say that cost is the #1 barrier to why they don't eat healthier foods. They want to eat healthier foods. 80% of people in America say they want to eat healthier. Cost is the #1 barrier. We know we can get this food to people, and the question is, who do we provide it to, how much, for how long, in what format, in order to make sure we're having the greatest impact? Because healthcare wants us to prove an impact, and they want us to prove an impact on cost. And so I'm going to preempt your question about cost by saying that Corby will ask me about cost, and I will say I object to the question, and I object to the question for this reason. There's no medication in the United States that we have decided to cover or not cover based on whether it's cost savings or cost neutral. We cover costs because they improve our health, because they've shown that they're effective. And there is a case in the United States where we have developed a tradition of holding interventions that have to do with people's behaviors, that have to do with social needs, that have to do with food insecurity and other social determinants of health, that have to do with prevention. We hold them to a higher standard, a standard of returning money to the healthcare system. But why are we trying to return money to the healthcare system when we're talking about lack of access to healthy food?
Okay, we're going to be hearing more from John about exactly digging into cost. But John, before that, Hillary, could you give a thumbnail definition of medically tailored meals, medically tailored groceries, and produce prescriptions, recognizing we have a world expert in the room in David Waters, but would you like to, because it's different from hospital food.
Yes. Okay, so food as medicine interventions or programs are a nutrition intervention that is integrated in some way with the healthcare system. So usually there's a referral or a prescription from the healthcare provider or from the health system to a grocery store, a community-based organization, or some other provider of food. In the case of medically tailored meals, they are ready-to-eat meals that have already been prepared for you. In the case of medically tailored groceries, they are usually a box of healthy foods that you have to cook and prepare at home. And in the case of produce prescription programs, they are vouchers or debit cards that you take to your own grocery store or big box store and exchange for the foods of your choice as long as it's produce.
Thank you. So much of this is queued up John because he has a very innovative and really effective way of using all three things you just defined. But before you get to that, can you tell us, how you got into this racket and why food when you started in an emergency room in Chicago?
So when Corby told me he was going to ask that question, my first thought was, well, I've been working in food as medicine for about 5 years. But then I began to reflect, actually, on my career. I started out as an emergency physician, and there were times when patients came into the emergency department, and we knew that the only thing that we really could do for them was to give them a meal. And then, as I've learned working in the emergency department, there's only so much good you can do at the tip of the spear of healthcare. That if you really want to have impact, you have to go outside of the emergency department into the community. And that led me on a pathway into public health. And I went through, after getting my master's in public health, I went into the Illinois Department of Public Health, and after a few years there, I was named the director, and I was responsible for a program called WIC, the Women's, Infants, and Children Nutritional Supplemental Program. And the results of this program was so incredible. Here was a program that within the same year saved Medicaid $4.50 for every dollar that was spent. This was my first introduction to using food to achieve health outcomes. I went from there to the Robert Wood Johnson Foundation, and midway through there, I picked up a program called Childhood Obesity, where we had redefined the whole concept, the narrative around childhood obesity, from personal responsibility and failures of the parents to understanding the energy equation, that obesity was related to exercise, energy out, and food coming in. Or so we thought. Because as we got more and deeper into this issue, we realized that there was no way to overcome the increasing increase of consumption of unhealthy food that was nutrition absence and dense on calories. Then I had the opportunity to go to the North Carolina, the Blue Cross of North Carolina. I was invited to come in by Patrick Conway, who was the CEO, and his successor, Dr. Tunde Sotunde, all of whom pointed me in the direction and said, John, we want you to address the non-clinical drivers of health in order to have better outcomes for our members. And the first issue that we addressed, because when we looked at the data, the number one social driver was food, lack of food. But we had the challenge. I believed deep in my heart, from everything I had learned in my career in public health, from public health school, that prevention works. I believed that food was directly related to all sorts of diseases, heart disease, cancer, stroke, diabetes, metabolic syndrome. But what was missing was the evidence of what you do about it. And we set out to do that with the support of the CEO of our company. We were allocated funds. We had to convince the actuaries. In fact, we had to convince the chief medical officer, who, even though he had a career in public health, says prevention doesn't save money. It achieves great outcomes. But we engaged in a pilot. We called it Food Delivery Health Coaching. And within 6 months, we were able to demonstrate better health outcomes, lower weight, and lower healthcare costs. We published the results in the Catalyst section of the New England Journal because our commitment was to influence the field of health insurance. And then we took it to scale with a program called Feed Your Health. And what Feed Your Health does, it starts off with medically tailored meals. In other words, it trains the palate of the individual with diabetes. And then after a period of about a month of that, we go to medically tailored food boxes. In other words, food boxes that are delivered that are tailored to that individual's health needs, in this case, diabetes. They go from training the palates to learning how to make the meals themselves. And we went from that to food prescription, which is giving them a card they can take in a grocery store, which is good for fruits and vegetables, for produce. So now they can learn how to shop for themselves. And then after that, we go into the next phase, which is continued support throughout this time with a health coach, a dietitian, or a community health worker. And then they proceed to go into a 6-month period where they just have an application. But one of the lessons that we learned is that the solution to diet-related diseases is not technology solution. Yeah, it's a technology solution. And I'm a tech nerd. But it also requires not only high tech, but high touch. And so as we began to implement the programs, we looked at how we can engage community-based organizations in this process of preparing and delivering the food, because they're the ones who can directly work with our individual members in their communities and help them get to a healthier condition. So our belief, as we continue to do our work, as we create the evidence, is that we can move from an environment that we know from the data about our population where food makes us ill to a future where food can heal.
Great. And applaud. But now, tell us, how did you make this no cost? You said this was a no-cost intervention, and that really helped with your actuary friends.
So one of the challenges in health insurance, and Hillary and I have these conversations all the time, which is, and our CEO takes this quote, it's not from him, but no margin, no mission. We're a nonprofit blue. That means that we don't have shareholders. And as our CFO says, my biggest goal is that we have excess revenue so we can give it to our foundation. But when you implement a program, you have to demonstrate a return on investment. And that's what our data began to show. We could show that because we worked with the actuaries. We could show that because we created the data on our own members. And through a happy circumstance, when we did our initial pilots, because of a compliance issue, we did it with commercial members. Those are people who get their insurance through their employers. First of all, we found out that 20% of our commercial members were food insecure. But what we learned from our pilot program is that every member who has diabetes that's out of control can benefit from this program. So the data enabled us to develop this program, Feed Your Health, and convince the actuaries that we could at least break even, and actually with administrative costs, it reduced the total cost of care. Therefore, we were able to offer it to our customers, which are employers. And when people talk about health insurance, why don't they have food as medicine as a benefit? We just make the product, the customer buys it. And employers decide if they want this benefit or that benefit. But because we could demonstrate that this was a no cost, we applied it to the base insurance package. And that's what I mean by a no cost benefit.
And if you're really trying to be a catalyst, the New England Journal says, to the rest of the healthcare systems in the U.S., how come every insurer isn't offering this as a no-cost benefit to employers that buy from them? I know you can't really answer that, but it certainly is a question.
Well, I mean, the easy one is because we're Blue Cross of North Carolina. But we've had the commitment from the top levels of the company and a commitment to non-clinical drivers of health. And we created the data on our own members. There is a challenge, and the challenge is that food as medicine is conflated with food insecurity. And people start to think about food as medicine as something for people who are on Medicaid. What our data has shown is that food as medicine cuts across everyone, all types of insurance. And we're hoping that our experience, we've implemented this program, we're seeing really good results. We're going to wait till we have a year's worth of data. We're going to publish that. And we think that will help encourage the rest of the industry to join.
It's also important to say, I think you went from philanthropy to Blue Cross Blue Shield, the actual business, the insurer. There's a nationally significant foundation of Blue Cross Blue Shield North Carolina, but did you go to the foundation or to Blue Cross Blue Shield, the health system?
Yes.
I see. I think. But you got buy-in from the heads of the healthcare plan.
So I was hired to work on the foundation, to be the president. And then after I was there for 6 months, they figured they had a deal. They could also have me in charge of our drivers of health work at the same time. So I actually worked with the foundation and with the company. And the foundation has had over 10 years of work in the food system. And so the benefits of using the resources of the foundation and the resources of the company to carry out our purpose, which is to improve the health and well-being of our customers and community. And we won't stop until healthcare is better for all. And that was, for me, a golden opportunity to use all the tools that are possible to carry out this public health mission.
I'm teeing up something for Wendy, and that is, I got to go to Durham and hear there's a sort of a festival of John Lumpkin's work, and he was so modest. He had nothing to say until the end. Finally, at the end of a very long day of people from all 100 counties of North Carolina. Who knew there were 100 counties? Each of which he toured with numerous people who'd been to this conference. Somebody got up and said, "None of this would have happened without John Lumpkin. Can we at least acknowledge that?" But when you were doing that, what did you find were the keys to getting community buy-in, including there were some very funny stories of diffidence, like from church members, but you enlisted faith leaders, small and large organizations. Can you talk about finding them and engaging them?
Well, that's where the partnership with the foundation really was critical. Our foundation believes in community. We center community. We center partnerships between healthcare and community, but where community leads. And so we've had years of experience of very direct engagement. We knew who the individual leaders were in food as medicine. Reverend Joyner, who you mentioned, in a little town called Coneta. You won't be able to find it on a map because it's spelled Conetoe. But when you get to be in North Carolina, you know that people don't always pronounce words the way they're spelled. This was a reverend who was preaching at funerals of people who were 50 years old who were dying for diet-related diseases. And he said, we have to do better. And he worked with his parishioners to change the diet at the church gatherings, and taking their fried chicken away from them at those gatherings was almost an existential experience for him. And he started up a farm where he brought in kids who didn't know where their food came in to learn how to grow healthy food. That's just one of the many examples of people in the nonprofit sector. That's why we knew, as we were implementing this, that it had to be a yes-and approach to developing food as medicine.
Great. Thank you. Wendy, how did you get into this and start engaging communities?
Okay, well, I'll start with a story, but before that, I want to say I've been a beneficiary of Anthem Blue Cross National Foundations many times for salad bar research, so thank you for that. I'd like to begin with a story, one that stays with me since I was 5. It was sun-drenched afternoon, and I was picking string beans with my favorite Aunt Maxine. The harvesting was pure joy. But then came dinner. I sat at the linoleum table, silently horrified at a plate of steaming green beans. I hadn't mentioned I didn't like them. But Aunt Maxine, with a twinkle in her eye, turned the moment into a game. One bean plain, one bean with salt, one with butter, and one with both. I tried each, the last just right, Goldilocks style. That day wasn't about just beans, it was about change. Changing minds takes time and many flavorings. That insight stuck with me. In high school, a biology teacher offered a nutrition elective based on Jane Brody's personal health column in the New York Times. I was hooked, not just by the science, but by how Jane Brody transformed evidence into stories that moved people. In college, I started a newsletter called Healthy and Wise, and worked on nutrition research with Chilean physicians exiled after the fall of Allende. They were stunned by how little US doctors knew or seemed to care about nutrition. I promised myself I wouldn't be one of them. But I wanted others to care too. In 1982, amid food insecurity in New York, I borrowed the CBS documentary Hunger in America from the public library. It followed the lives of US children facing hunger. I screened it for my medical school classmates, hoping it would hit home. For some it did, for others not so much. But I wasn't discouraged, as Aunt Maxine taught me, if one approach doesn't work, try another. Just don't stop trying. That philosophy carried me across continents with Save the Children Federation and back to the US universities, where I helped navigate and teach breastfeeding and nutrition into pediatric training. But embedding nutrition into UCLA's medical student curriculum remained elusive. The breakthrough came in 2011 when I was invited to lead the food initiative at UCLA's Semel Healthy Campus Initiative Center, eventually overseeing the entire center. Our bold charge was to make UCLA the healthiest campus in the nation, serving 85,000 students, staff, and faculty, and create a model for others. Today, that model has been adopted across the UC systems, and hence I know Hillary. How did we do it? We took a community organizing approach utilizing asset mapping, collective impact, and a socioecological model. We engaged all sorts of partners. We asked who drives health at a university? How do we bring them together to act on shared goals? The Food Studies Summit we hosted brought together 60 students, scholars, and leaders. What followed were 5 clear goals: build a teaching kitchen, create an urban garden, establish a food studies undergraduate minor and a graduate certificate, and launch an institute for food studies. Now, this is at UCLA, and in 8 years, we've done it. Thank you. It was a tall order, but we did it. So why a teaching kitchen? Well, because 35% of UCLA undergraduate students were food insecure at that time, and unfortunately, they still are. They didn't just need food, they wanted skills, confidence, joy, community. We now have 2 teaching kitchens, an endowed chef, a food-focused librarian, and deep integration into the health sciences curriculum. I was initially skeptical about a teaching kitchen, how it would fit into a medical education. But when I watched a first-year medical student learn how to crack an egg, I was completely won over. It was shocking, actually. Early research shows UCLA health science students in the teaching kitchen gain confidence in nutrition literacy, cooking skills, and patient counseling. Our teaching kitchen research program has expanded into a multi-site clinical trial on food as medicine with partners at Harvard, Dartmouth, UC Irvine, and the University of Houston. Now, food literacy, I don't have to tell everyone here, isn't just about nutrients on a label. It's cultural, emotional, scientific, and political. And the heart of it all is storytelling. And I've heard a lot about storytelling today from other panels. Stories are how we make meaning. They shape how we connect, heal, and grow. They help stay us human amid rapid change. A few years ago, I want to share one last story then. A few years ago, I casually logged into my health chart, expecting routine results. But there was a red exclamation mark next to my hemoglobin A1C, 6.2%. I was pre-diabetic. As a physician who once warned audiences about the silent epidemic, I realized I was part of that story. That night, I looked down at my bowl of vanilla bean ice cream and thought maybe I could rewrite my story. I revamped my diet with a focus on nourishment, not restriction, and within 10 months, I reversed the diagnosis. And I had one of those ice creams here earlier. It was very good. That wake-up call deepened my commitment to prevention. So I ask, what stories are we giving tomorrow's health professionals about food? Are we preparing them to prescribe it with the same confidence as medicine? Are we treating nutrition as essential to health equity or just another elective? The road ahead is long. A 2015 report found US medical students receive on average 19 hours of nutrition education over 4 years, and most of that is in biochemistry. As a doctor and the daughter of a California farmer, I'll say this: we reap what we sow. And right now, we have a generational opportunity to plant the seeds of a truly nourishing healthcare system. Thank you so much.
All right. Hillary, I've got a very serious question about food insecurity and using nutrition interventions, and this conflation of the two. Conflation is a very good word that John used. But picking up on what Wendy said, at UCSF, has culinary medicine been a term? Has nutrition education been a thing? And is it really difficult to try to implement it there as it was for Wendy to do at UCLA?
Let me answer it this way. 13.5% of households in America are food insecure. They are sometimes worrying that they don't have enough money to afford food, or they're going without food, or they're changing the quality of their diets because they have to meet a really low food budget. One of the incredible strengths of the last 50 years in education is that we have drastically opened the doors to students of every socioeconomic status to work their way from high school to college to pharmacy school or nursing school or medical school. And what that means is that the percentage of students in our medical schools and pharmacy schools and nursing schools who are food insecure is very, very high. And we have an obligation to support them in making their food budgets and allowing them to eat healthy foods, because it's also critical for their success in medical school or nursing school or pharmacy school. You can't show up to school every day and perform your best if you aren't able to access healthy food. A low-income household in America, let me say that again. A low-income household in America has to spend up to 70% of their entire food budget on fruits and vegetables in order to meet the dietary guidelines. 70%. So we have to start thinking of poor diet choices, this is what we call them, poor diet choices, as rational economic decisions. It allows you to get the calories you need to take that test at the end of fourth grade or at the end of your medical school block. And so what has UCSF done? A number of things to make sure that students who are accepted into our program have the tools they need to succeed, including the healthy food they need. And that's come in the form of food pantries, high-tech apps that take catering after conferences and distribute it to people who need it, and all kinds of other programming.
And what about the idea of culinary medicine? And Wendy, we certainly know, and Ron's organization works with a lot of medical schools that are trying to implement it, and cost is a huge barrier to the medical school departments. It's often like under a little rubric of the provost as a sort of cute little project that somebody has to prove can get buy-in from the rest of the faculty. What has it been like for you to get your medical school faculty to pay any attention to nutrition?
Well, as I said, after the summit, we decided to build the kitchens. It took a while, but I think the scientists and the medical establishment thought of a kitchen then ultimately as a lab, which was great. And so we were creating a lab that helped translate learning how to do culinary, not just medicine, but actually teach the skills to the students themselves. So then, and there's plenty of data that shows that if a physician has this interest and knowledge, that they're more likely to engage those kinds of conversations with their patients. And we have during orientation for medical school now, every student participates in the kitchen, so they all know it's available. And then because we have an endowed, you can't have a scientist, or you can't have a lab without a scientist, so we have an endowed chef. And so the chef is there and is available for any medical class or medical student to create a program within the context. So it's all coming from them, not us telling them what to do. And the form of collective impact is bringing everyone together and agreeing on a common goal, and that's what and leaving your personal agenda at the door, and that's how we've been so successful with the medical school at this point. We still have a lot to go, but we are much further along. Again, especially what Hillary's saying, the students are asking for it, not just us. And we also, the nursing school, of course, went first. They were really into it. And they've been learning about how to manage all these chronic diseases through the teaching kitchen. And they're learning the recipes, they're hands-on, and also they're applying it to their own lives. And that was the data that we found, that they were actually improving their own practices as well.
Great. Chronic illness, and we are hearing a lot about the relation of chronic illness and food from the new HHS secretary. So, and the MAHA platform is full of references to food as medicine. And so I'm going to go down the panel, starting with Hillary. Wish list of actual policies that will be recommended, funded, and implemented, none of which we've seen, that would help the cause of food as medicine and reducing chronic illness. And whether you are as confused as I and others about what exactly the new administration means by chronic illness, which seems certainly to be autism, but maybe hyperactivity in children. But what do they think about when they are thinking about chronic illness? Hillary.
I will be brief. I don't think that my understanding of nutrition that is rooted in the dietary guidelines for Americans and decades of scientific study is the same term that is being called nutrition in the MAHA platform, but I can't speak to them as to what they do mean by it. I will leave it at that. My wish list. I know this is a food as medicine panel, but my number one wish list is that we maintain SNAP benefits. SNAP is the most effective poverty.
Absolutely.
The largest and most effective anti-poverty program in this country. It works. It works not only to reduce food insecurity, but to support health outcomes. So if I had a magic wand, SNAP first. And SNAP should be available to everybody. You purchase what you want if you're on SNAP, just like you purchase what you want if you're not on SNAP. The current efforts to restrict SNAP benefits to a certain basket of healthy foods will only increase stigma in the program. The problem with unhealthy dietary intake in this country is not people enrolled in SNAP. It is not people enrolled in SNAP. It's that our food industry is flooding the market with highly addictive, highly palatable, incredibly delicious foods that are targeted towards people of low socioeconomic status. It is not fair to fix that problem through SNAP.
Okay.
So, Hillary is one of my idols, and I hate to disagree with her. I don't think that SNAP is one of the most important anti-poverty programs. I think it's one of the most important health programs.
Ooh, I like that build.
The data is really clear for individuals on Medicare who are eligible for SNAP, who are enrolled, their health care costs are less. Did I say Medicare? No, I did say Medicare. That's what I meant. Yeah, and part of the challenge that we're facing with some of the policies is that by putting extra requirements on enrolling in SNAP is just putting more red tape on top of people who are either working for they're living and eligible for SNAP, or seniors who are on Medicare. And I talked about how difficult it was to convince the actuaries for our food delivery health coaching. Convincing them about the ability for us to do enrollment for Blue Cross members who are on Medicare into SNAP as a program was a snap. Because the data is so strong.
But what would you like the current administration to do?
Okay, so I'm just going to focus in on where I'm at and my job. We create so many barriers to food as medicine through the policies that are in place by the current administration and the previous administration and the administration after that. Health insurers under the ACA are required to spend a certain percentage of the cost. 85% of the premium dollar has to go to healthcare services. Food as medicine doesn't count. So that makes it like trying to make the business case even more difficult. And in Medicare, and I won't go into all the machinations because it took me an hour with an actuary to understand it. But for Medicare Advantage, it's even worse. If they could just remove the barriers, remove the red tape, so that food programs like SNAP, like food benefits, supplemental benefits in Medicare, like WIC, if we remove the barriers so that people could get access to these critical programs, that'd be my one wish.
Okay, great. Wendy, I think we went through some of this. I'll prompt you if not, but have you got a wish list for the current administration?
Yes, I'll just echo the wishes of my colleagues here and add a couple. Farm to school program needs to be reinstated. It's really
Say what the farm to school program was.
It was, as of like a month ago, I think, or 2 months ago, it was where local farmers were able to sell their produce to the local school districts. So it minimized, the carbon footprint. It obviously was much more fresh, and it also invested money into the local economy. Gone.
$1 billion
Yes, thank you.
that farmers were counting on this year and
And
made
it got-
infrastructure changes and spent a lot of money counting on that money.
And let me
Red
just add
line.
one other thing to that.
Yeah,
They've already got the seed in the ground, those
Yeah.
farmers.
right. They planted.
They planted, so their
They're
economic
out.
future is determined on a crop that they won't be able to sell.
And it's a lot of small and medium farmers as well. I mean, it's just for the family farmer, for the person, the small businesses, the people that are the ones trucking it also. I mean, there's a whole, food chain. WIC program, you mentioned how important that is. We better keep that. And
Refresh everyone's memory what it stands for and what it does.
Women, Infant, and Child Supplemental Program, I believe. And it's one of those programs that was instituted after the Hunger in America documentary that came out in the late 60s that horrified people. By the way, that was RFK Sr. who produced that film. And horrified people that there was starvation in the United States. And that moved all the Congress, and also Nixon signed all the legislation. WIC, SNAP, the lunch program became established across the country. I mean, it was an incredible moment for helping our families and our children. I'm a pediatrician. I don't think I mentioned that. So it's near and dear to my heart. And then my other piece is that, so I would watch that movie, by the way. It's very moving. It's different because it was 68, black and white, but it's very important to show it and see where we might go back to. And then since I was asked to talk about education and higher education, universities, I was involved with the breastfeeding work I did. We got funded by HRSA and USAID to teach teams of faculty to teach it to the next generation, because the challenge is right now is that we don't have enough people to teach nutrition in the health sciences. We have probably a few embedded in each university, but not enough. And so what we need is the champions. There's plenty of champions in each of our universities or medical schools and nursing schools. We need funding for that. We need to get a broad stroke funding mechanism so that we can teach it, and we can teach it the way we think, not what Hillary's saying, the definition of nutrition. We don't know what it is on one side, but we do know what the definition is. So that's what I would like
It's time for Q&A. I assume there's just very few, but I'm just kidding. We have a hand up in the third row and then the second row, and mics are right there.
I'll be brief. I have a question for Dr. Lumpkin, if I may. I live in South Carolina, and I serve in the General Assembly and the legislature in South Carolina. And I'm wondering if the program in North Carolina is being replicated, Blue Cross at Blue Shield of South Carolina, or other locales near North Carolina, which share similar demographics. I think our health outcomes are much worse than North Carolina's, but we would benefit from a program like that.
I agree. That's why we're trying to share our message and to encourage other insurance programs to do this. But I think it was one of the large investment firms that said that 2024 was the worst year on record for health insurance programs, for health plans. In 2025, we expect is going to be worse. So as much as I'd like to see my colleagues in other health plans do that, I think that this is something where we have to continue to put out the message, and I think that they will begin to adopt it.
I know in our state, with the ACA being the supplemental amounts that are being covered is going away, and that's going to affect people who are going to be on insurance and significantly affect the health outcomes that we have in South Carolina. So.
Yes, ma'am.
Second row then.
My name is Chase. I'm a founder for Sadiku.cloud. We're building a platform for menstrual and menopause care. And one of the quick reasons that we did a recent survey was how much more do women in the workplace who are dealing with PCOS, endometriosis, want to be able to have, like those who are craving for chocolate, for example, wanting to have gluten-free resources. But my question directly to Hilary, for example, we've had ACA, SNAP, Big Beautiful Bill, and a couple of other programs. How does that help right now with technology founders who are building currently and seeing how much more we can start replacing food as a supplement for those kind of courses, and also incorporate them into employee network?
And John, Hillary and John, I think.
Well, let me start by saying that one reason that I really like produce prescription programs is that it preserves choice. And people have very different barriers to eating fruits and vegetables. Some people are just never going to eat broccoli. Whatever, it's fine. Don't buy broccoli. Some people's dentures don't work well. They want to eat bananas, fine, buy bananas. So I think choice is a huge thing. And when you're talking about food preferences around PCOS or endometriosis, like you talked about, there are food preferences, and we should, wherever we can, acknowledge and honor those food preferences. Food, one of the reasons I hate the term food as medicine is food isn't just medicine. Food is people's identities, food is people's culture. Food is a human right. We don't even agree that medicine is a human right in this country. Food is a human right. So I will answer your question that way. And from a technology perspective, I will say I am still waiting to see the technology that can help solve this very difficult problem of a food system that isn't working. I haven't seen it yet. I think if I had a technological magic wand, it would be to find a way to convince the food industry by regulation or not by regulation that the foods they're exposing people in this country to is making our country ill.
Okay. John, we have a question in the front row, and then, but John, you're the tech nerd. So could we have the mic right there? And then, so John first, then
Yeah,
question.
I would say that, first of all, we have to look at food as medicine in the context. And the context is, it is not a silver bullet. For people with diabetes, food as medicine is part of a comprehensive program of management and reversal. And so technological solutions are part of that. They are not the solution solely by themselves. And so I think that the challenge is that when people are pushing a product to say this will solve it, they need to say this will be part of the solution. And it works along with other aspects of the food as medicine and diabetes management and control.
Great.
I don't have a question. I'm sorry, but I do have a statement of hope. My husband and I own a company called the Wonderful Company, and we make only healthy products. We also give free health care to 12,000 people in the Central Valley of California.
Wow.
We have reduced prediabetes by 60% in our company by only serving healthy food, getting rid of vending machines, teaching people how to cook, and also giving them food to take home for a family of 5, because there's always mom or grandma or somebody extra, that is $15, and it's a beautiful, healthy food. Also, our children in our schools, we cook 3 meals a day of healthy food from scratch for under $4.17. It can be done because these kids weren't able to think. They never ate breakfast, and they had a bag of potato chips for dinner. It's a big underserved community, and we're changing the cycle of poverty by doing this. And our healthcare costs are 30% less than they were before. Or there are a few people in the program that don't go to our clinics, and their healthcare costs are 30% more. So it saves money, and it makes for a healthy society. So there is hope. Thank you. I'm sorry I didn't.
Thank you. Okay, on that ringing affirmation that food could be medicine and change can be made on small, large, national, and global levels, I want to thank our inspirational panel and audience.